Okay, so now we will discuss something about benign breast diseases, surgical anatomy. Okay, these points we'll discuss, which is not so important as breast cancer, but sometimes questions may be asked here. Okay. So identify the investigation.
CT.
Mammography.
Mammogram, no.
CT guided
Biopsy. CT guided biopsy.
CT guided. Okay. Actually, it is both CT or stereotactic core biopsy. Because it is exactly stereotactic core biopsy, but the picture is not so clear. It may be CT will be, there will be a console here, and patient will be sent inside that ring. There will be a ring, right? You have done anyone undergoing CT, you have seen, right? There will be a ring-like thing. The patient will be sent into that. Okay, so there will be a coil outside. So this is actually a stereotactic core biopsy.
So can you please explain that word, stereotactic?
Yeah, I'll tell you. I'll show that image. See, this is the mammogram. Mammogram is this one, like just like an X-ray. This is an FNAC. This is a true cut. I told you already. So this is a stereotactic. Stereotactic means you will know you can control the vision. See, the breast is, you can see multiple slices like this. Slice 14, slice 18, like just like a bread slice. Yesterday we were discussing axillary. So you know the exact lesion where it is, and you can point your instrument there exactly to the lesion and just take a biopsy. That is stereotactic. Stereotactic means under your control. Okay. It is possible only in real time. Just if you do an OPD, just if you put a needle inside, we can't get it. So image guided along with biopsy, both done at the same time is stereotactic biopsy. Okay.
Okay, sir. Thank you.
So I am talking about axillary lymph nodes, right? Axillary lymph nodes. There are pectoralis major, minor muscle will be like this. There are 3 groups of lymph nodes. Level 1, level 2, and level 3. What is level 1 include? Level 1, what are the lymph nodes involved in level 1?
Anterior.
Yeah.
Posterior and lateral.
Anterior, posterior, and lateral. Very good. So level 1 is anterior, posterior, and lateral. Okay. Level 2, that is behind the pectoralis minor, back of pectoralis minor.
Central group.
Okay, central group. Okay. Then what is 3? What is that 3 group?
Apical group, sir.
Apical group. Apical.
Okay, apical.
Okay, so there are 5 lymph node groups which are divided into 3 zones. Zone 1, Zone 2, Zone 3. Anterior, posterior, and lateral are there in Zone 1. Anterior, posterior, and lateral there in Zone 1. 2 is behind the pectoralis minor, that is central. 3 is apical. Okay, just remember this diagram. You will. This is anterior, posterior, central, and this is central. If central we can't see, it is behind it. Anterior, posterior, lateral we can see, and apical we can see again. Okay, what is the specific name given to this interpectoral nodes? Anybody? Interpectoral nodes. Interpectoral nodes, what is known as? Rotor's lymph nodes. Rotor, R-O-T-T-E-R, Rotor's lymph nodes. Okay, so just tell me this answer.
It would be an MRI.
Others also?
MRI.
Yeah, answer is MRI. I told you. What is the other indications for MRI?
high risk females with a positive history or BRCA mutation.
Okay.
And also for implant related complications.
Okay.
And this one to
Scar and
differentiate
recurrence.
scar, yeah, a recurrence as well.
Okay. Identify. Tell me this one.
First, being less
Is it option A?
rapid and painless.
Very good. It is less invasive, rapid, and painless. Will FNAC differentiate invasive and in situ lesion?
No.
No.
No. Will it tell the receptor status? No.
No, sir.
Once you don't know this, you can't plan neoadjuvant treatment. So it is less invasive, it is rapid, and it is painless. Yeah, this one. This I'll discuss now, but just try identify the mismatch here.
So can it be B, option B?
Yeah, excellent. So why is it option B?
Because it's just mastitis. You don't have to retract anything. You don't
Yeah.
have to do a surgical
Circumferential
procedure.
retraction is seen in malignancy, not in just infection. It is chronic periodactyl mastitis. No, circumferential retraction is seen in malignancy. Okay, slit-like is seen in ductectasia. Suppose see, this is the nipple, only nipple I'm telling. And if there is a single duct ectasia, if one duct is gone, there will be slit-like, just slit, only slit. Circumferential means whole of this nipple is gone, whole of the nipple is retracted back. That it is seen in malignancies only. It is not in mastitis. Okay, so this is wrong. The others are correct. Bloody discharge from the nipple, it is seen in papilloma. If there is a ductal papilla, if there is a duct, if there is a papilloma, there is bloody discharge. And serous discharge is seen in fibrocystic disease of the breast. So these are the four things which you should remember: slit-like retraction, ductectasia, circumferential retraction, malignancy, bloody discharge, intraductal papilloma, and serous discharge in fibrocystic disease. So what is the treatment for this? Single ductectasia. What is the treatment for that? Ductectasia. If there is single duct, multiple duct. Single duct, microdocectomy. Remove the single duct only, microdocectomy. If there are multiple duct, remove the entire cone of the tissue. Hadfield's cone excision, we call it as. Okay. Suppose this is the nipple. These are multiple ducts like this radiating. If single duct is there, do a microdocectomy. If multiple ducts are involved, then do a cone excision. Just remove it as a cone. Okay.
Could you please show the previous slide again?
Yeah.
Please.
Yes, sir.
1 minute. Okay.
Yes, sir. Okay, sir.
Yeah. Identify the following. This picture is not clear, but it is taken from Bailey directly.
Actinomycosis.
No.
Mondo's disease.
Yeah, it is Mondo's disease. Yeah, it is taken directly from Bailey, so I may not help you. But Mondo's disease, it is thrombophlebitis. Thrombophlebitis of veins over breast wall. Thrombophlebitis of veins over breast wall. Okay. So this is known as thrombophlebitis of veins. So this is known as Mondo's disease. Just see that. You can see here. See this one. This one. Are you able to identify it? Yes. No.
Yes, sir.
Yeah. Fibroadenoma. What is a fibroadenoma? Is it malignant or it is benign?
Benign.
It's a benign lesion of the breast. Okay. So just see the options and identify the true statement. Just guess, because this I did not cover now. You should I'll cover now, but just guess. What is your perception regarding this?
B.
Treatment of giant fibroadenoma cannot be mastectomy. It's benign, so that's out. Giant fibroadenoma occurs commonly in aging females. No, it's also not true. It happens usually more in young. Even if clinically obvious, a biopsy should be done if the patient is over 25 and there are any atypical features on ultrasound. Yes, that's correct.
Yeah.
Yes,
So,
so option D sounds more
yeah, it's sound
appropriate.
logical, right? Giant fibroadenoma is more than 5 centimeters. It's not 3, it is 5. Okay. And giant fibroadenoma occurs commonly in aging females. No, it occurs in young and middle-aged females.
Middle-aged females.
Middle-aged. Okay. Treatment of giant fibroadenoma 5 centimeters. No need to do mastectomy. You can just remove the lesion. But this is correct. Even if clinically obvious, if you feel it is obvious, but never miss a breast mass in an elderly or a middle-aged female with atypical features on ultrasound is a malignancy unless proven otherwise. Okay. Like the same way in the scrotum, yesterday I was telling you, there is a scrotal mass. Okay. Then you should think it is a testicular cancer only unless proven otherwise. Okay. So even if clinically obvious also, biopsy should be done. Once if there are atypical features on ultrasound, this is the true statement. Okay. And on mammogram, if you do a mammogram for this patient, there is a classic appearance. Can anybody tell me?
It's called popcorn calcification. Which is
Yeah, popcorn calcifications are seen in this popcorn calcifications. Okay. Suppose, so the question can be asked like this. If 35-year-old female came to you with a breast mass, mammogram suggestive of popcorn calcification in the breast. So the answer is, so the diagnosis is, like that questions may be asked. Okay.
So it's called as the mouse of the breast.
Yeah, it is known as breast mouse because it is very much
mouse.
mobile. So it is known as breast mouse. Okay. So now answer this.
Option C,
Yeah. Why option C?
leaf-like appearance.
Yes. Single word. Leaf-like appearance. Pilloid is leaf-like. So see, it is a disease of middle-aged female, and it is origin is dual origin. The phyllodes tumor comes from mammary epithelium and connective tissue. Both. Phyllodes tumor is from both. Breast cancer is only from the duct or lobe. Here it comes from the epithelium, both the duct and lobe, and also with the connective tissue. Okay. So it has a leaf-like appearance. Once you take a tumor and cut it, it just like looks like a leaf-like appearance. Okay, that is a phyllodes tumor. So this is phyllodes tumor. See here, this is a phyllodes tumor. It is bosselated. It is leaf-like. Any terms, these are the key pointers. If these findings are there, then please mark phyllodes tumor. Okay, pointers. Bosselated, leaf-like. They are having very low malignant potential. Okay, and spreads via hematogenous way, bloodstream. So these are the 4 points. Okay. Yes, no?
Yes, and it's the fastest growing tumor. It grows very fast in very short term.
No, like see, there are multiple types of benign phyllodes tumor. There are 3 categories actually. One is a very much benign looking, one is a very much malignant looking, one is an intermediate one. Only that third category which will go very fast. The first 2 are very slow growing. Okay, don't get confused with that. There are 3 individual types of phyllodes tumor again, but that is not necessary for us. So these pointers like bosselated, leaf-like appearance, They have very low malignant potential, but there is no zero malignancy. I'm not telling. There is low malignant potential. They are met via bloodstream hematogenous spread. And this you have to answer. Which of the following benign breast pathology predisposes to breast cancer?
Atypical hyperplasia.
Excellent. Others also clear? Yes, no?
Yeah.
Yes.
Yes, sir.
Yes. So slightly increased risk is up to 2 times, moderately increased risk up to 5 times for atypical hyperplasia. This one you have to answer.
Luminal A.
Option A.
Yeah, luminal A. Luminal A. Okay. This is for people who prepare for NEET also simultaneously. There is a score for estrogen and progesterone receptors on breast. This is known as Allred score. Allred, option A, Allred score for estrogen progesterone receptors. I was discussing, right? For premenopausal, postmenopausal, we were discussing. So there is a score called Allred score, option A. This one?
M1.
Yes,
Bilateral
M1.
supraclavicular
Bilateral, yeah.
metastasis.
What is T4D? T4D?
Tumor stage 4.
Inflammatory cancer.
It's inflammatory.
Yeah,
Yes,
it is inflammatory cancer. Good. This one?
Tram flap.
Tram flap breast reconstruction.
A. Option
Breast reconstruction and tram flap. So it is based on which artery? Tram flap is based on which artery?
A. Deep epigastric
Deep
perforator
inferior
artery.
epigastric perforator artery. Deep inferior epigastric perforator artery. Okay, this we have discussed. And this is also just next level question. A post-mastectomy specimen's HPA report consists of a solid sheet of large cells, often associated with marked lymphocytic reaction. This is medullary cancer, medullary carcinoma. No need to go into it. Just remember, lymphocytic infiltration is there, then medullary cancer. In the same way, evening when we discuss thyroid, I'll tell you lymphocytic infiltration is there, and which thyroid it is? Starts with H.
Hashimoto's thyroiditis.
Hashimoto's. I'll discuss there. Hashimoto's. In the same way, here also there is marked lymphocytic reaction in medullary cancer. Okay. In medullary type of renal cell cancer, yesterday I was telling you, in which patients this is seen? Medullary type?
Dialysis.
Sorry?
Dialysis.
Dialysis.
In sickle cell, what is there then?
Papillary.
No, you are telling the reverse. In sickle cell, medullary is common. In dialysis patients, papillary is common. Okay, just go through it once again.